Okay, now your patients have gone bionic. What do we do with them? And usually, more importantly in this area, they show up and they say, when can I play golf? I think in the hospital, getting them out of the bed the first time, when can I play golf? So physical therapy goals have not changed that much as far as post-joint replacement therapy. Inpatient is still manage pain, edema, get them moving, minimize the risk of infection, PE, pneumonia. You want to get them to the edge of the bed, get them to the chair. Usually if it's a first day surgery, they're hopefully moving later that day, if not the very next day. Sometimes twice a day, if maybe not on the weekends or when you have power outages. But usually it's, we learn now within 3 to 4 days they're going to get to rehab or sent home for home health. It's all about getting them moving, getting them safe and ready for the next phase. So the old-fashioned, or at least probably still the standard, but we're not seeing it as much, is the hospital 3 to 4 days, sent to rehab for about 5, maybe 7 days, home health for 5 to 7 days, and where I've spent my whole entire career in outpatient sports medicine, they're usually 3 to 4 weeks post-op at that point. More often than not now versus when I started practicing, patients are coming in as early as 1 week post knee replacement with staples and all the gore still there. Sometimes they don't even go to rehab, they go straight home. They don't even get home health, they come right in, or they go from rehab straight to the outpatient clinic. So we're definitely seeing a lot of change and a lot more aggressive rehabilitation for these patients. The goals in outpatient PT are still the same. You want to minimize their pain and edema, soft tissue mobilization, effleurage, petrissage, cryotherapy, electrical stimulation. We have all the tricks and tools of the trade to reduce pain and swelling. You definitely want to be working the kneecap, the patella mobilizations for post-op knee replacement patients, minimize scarring and adhesions. We certainly work a lot on range of motion, passive, active assisted, active range of motion. There's a whole lot of stuff that we can do. As soon as they can tolerate, we want them walking, we want to do balance work with them, weaning off any assistive devices if they're showing up at outpatient still with a cane or a walker, although I do think that that's a much lesser trend these days. You're working on the hip and the knee and the core, the ankle. You're working on the whole body, the whole kinetic chain, either in weight-bearing or non-weight-bearing right from the get-go, even in the hospital from the very first day post-op. And even in rehab, patients are getting on the bike, they're getting on the new step, they're doing endurance training maybe 5 or 6 days post, and that certainly continues through the whole plan throughout the whole plan of rehab. And then more specifically around 2 or 3 months post, we'll start talking about sport-specific training. So for range of motion, and I apologize to Dr. Crow and Dr. Vitale because obviously this talk focuses on knee and hip and shoulder, but for range of motion goals, we typically want to achieve full extension for our knee replacement patients and about 120 degrees of flexion. And there's nothing more daunting as a clinician to face your patient who is crying with fear of achieving 120 degrees of flexion. So I try not to focus on that too much in talking to them, and you do what you can to try to achieve that range of motion, but a lot of patients just can't get it. And I think it's important for us to remember function is an important goal, pain is an important goal. As far as the surgeons and the therapists are concerned, we love to see 120, but a lot of the outcome data for reduced pain and improved function does not always correlate to 120 degrees. So it's important to take each specific patient into account, especially if they had severe arthritis to begin with and probably haven't had a straight knee or bent to 120 degrees in years. For a total hip replacement patient, I focus a lot on the adductors and the hip flexors because you have to focus a lot on the strengthening of the abductors and the hip extensors. If you have a tight groin and hip flexor area, you're not going to get full hip extension. So you have to really loosen up those hip flexors and adductors. And more specifically, I'm seeing on the younger total hip replacement patients coming back a year or two later, not with any loosening or wear and tear issues, but with hip bursitis or hip flexor tendonitis again, which they probably had for years before they had the replacement. So we want to, in order to prevent them coming back with issues, we want to make sure the hip flexors and adductors are lengthened appropriately. And for total shoulder replacement patients, mobility is usually not an issue. I've never had a total shoulder replacement patient that you can't get at least functional range of motion, 160 degrees of flexion and scaption and rotation there. We definitely focus more on strength and stability. The shoulder obviously inherently a more mobile joint. Like I said, I've never personally had an issue with range of motion, but we really want to focus on strength and stability for the shoulder. And specific goals for strengthening for these patients: in the total knee replacement patients, quadricep weakness is usually the biggest predictor to having persistent limited function in postoperative patients, so we really want to focus on strengthening the quads. And again, in the hip replacement patients, the extensors and abductors so that they can function, get out of a chair, get in and out of a car, golf, play tennis, all those fun things. And again, in the total shoulder patient, rotator cuff, the periscapular stabilizers, and the deltoid. Return to physical activity. In the new Orthopedic Sports Health Journal, there was a really good article last year that it had a great review of the evidence as far as what are total joint replacement patients getting back into, again, focusing on hip, knee, and shoulder. It's a great reference. And this is probably the biggest, nobody really knows. What can you do after a joint replacement? There's no exact gold standard, but studies have shown that if you're sedentary, you have a higher rate of complication or revision compared to your more active counterparts across the spectrum, whether you're 50 or 80. But then you also have studies that show much more higher active patients, and also younger patients also have a higher rate of complication and revisions compared to their less active counterparts. So you know you shouldn't be a couch potato, and maybe you shouldn't go play hockey, but somewhere in the middle, you can do some physical activity to stay healthy, but also increase the longevity of your prosthesis and avoid a revision or complication. So factors to consider, I think most surgeons and rehab professionals will tell you from the evidence and from their experience what you should and shouldn't get back into. But I think the biggest thing you should remember is each patient is different, okay? And each patient's goals and each patient's physical, how they present to you physically they are different. So you might tell one patient they can't play singles tennis, whereas the next patient you can tell them, sure, at 2 months post, go for it, So you have to take into account several factors. General health and age are obviously important. We typically don't want patients to start becoming a singles tennis player if they've never played single tennis before and they just had their knee replaced. So prosthesis type and joint replaced is important to consider. The specific activity, whether or not they participated in the activity before surgery, so preoperative involvement is also important. These are all things that you go through your mind when you're answering your patient, when can you golf, when you can play tennis and paddle and all the other things that people play around here. General guidelines to consider, and this is based on the evidence: avoiding high-impact contact sports. I've had patients, younger hip replacement patients, go back to playing full court 5-on-5 basketball. That particular patient had to have a revision, however, so maybe not a good case report. Most studies have shown that running is definitely a high-impact activity, although I have had patients go back to jogging, light jogging, or walking, jogging intervals. So there's, again, no set standard, but you have to take each individual patient into account. You always want to advise your patients about the risks: loosening, prosthetic failure, revision. And you want to advise them about the low-impact activities and just follow your basic exercise guidelines, 2 to 3 times a week for resistance training to keep your muscles and joints strong, and then about 5 times a week for cardiovascular activity. Obviously, you don't want to send them off to pasture, but at the same time, you want to minimize that risk for revision and complication. So the green are basically green means go. You can participate after a joint or shoulder, hip, or knee replacement. You can walk, you can speed walk, you can even swim for even shoulder replacement patients, doubles, tennis, golf. All of those activities in the green are considered low impact, low rate of failure on these prostheses. On the right, they're considered high impact or contact sports and definitely cautioned against. And I starred skiing, Pilates, tennis, paddle, and squash because almost every patient I have participates in these activities. So somehow you have to make it work for them. And at the very least, you can advise them, this might not be the best, paddle tennis might not be the best activity to get back to after a knee replacement, but if you keep up with your exercises and you maintain that good range of motion, perhaps you can at least engage in the activity in some form or another. So in conclusion, this is a picture I found on the internet of a patient who had a shoulder replacement, so he's doing pretty good. For postoperative rehab, whether it's your wrist or your knee or your hip, you definitely want to restore strength, range of motion, and overall mobility as much as you can. Maximize the functional mobility beyond the preoperative conditions, because most patients will come in and say, well, the reason I got my hip replaced is because I want to play tennis, or the reason I got my knee replaced is because I want to be able to keep up with my activities. It's not always just about minimizing pain. Educate patients on returning to their sports and exercise. Make sure they have all the knowledge, understand the risks and the benefits. Not only do you want to exercise to protect health, but you also want to protect the life of the prosthesis and take each individual patient into account when you're devising some type of postoperative long-term plan for them. And that's it.